this would be partly orthopedics, but also partly cardiology. And so I thought I would try and bring those two ideas together. And it's partly related, actually, to some ongoing research that my group and I are involved in. Everybody thinks of osteoarthritis as something that happens in obese people because they're heavy. I wish to disabuse you of that concept as we go through this talk. Need to disclose that I will be receiving an honorarium from Cadilla Pharmaceuticals for giving this talk. So, osteoarthritis. It is an extremely common condition. We all know that. It's common the world over. In terms of older people, it causes more disability, probably, than any other disease that we know. Hip and knee arthritis, and particularly knee arthritis, are more common than any other forms of the problem. But not surprisingly, there are various variations in the prevalence of the condition in different countries. One of the first things we need to do is ask ourselves, is there actually a fundamental design error in the design of our joints? Evolution, to some extent, has actually not kept up with the fact that we are living older than the joints were designed to provide hunting and things like that. So that as we get older, we will get osteoarthritis. 100% of people in this room will get osteoarthritis. But why might that be? We need to think of osteoarthritis as a condition affecting the whole joint. It's not just a condition that affects the articular cartilage. And as we go through this talk, I would like you to think about the etiology of cartilage degeneration, which leads on to osteoarthritis. And that is the fundamental concept, the etiology of cartilage degeneration. So what comes before that to cause the osteoarthritic process that we see in so many patients? The blood supply of the knee, as you see here, is actually a very long way away from the articular cartilage. And the nutrition of the articular cartilage is provided by the formation of synovial fluid. And synovial fluid is a filtered fluid formed by the synovium, which lines, in normal people, lines single cell thick the inside of the capsule and is loosely adherent to that. So that the articular cartilage is a long way from direct nutritional supply from the blood, oxygen and other forms of substrate. The amount of synovial fluid that changes throughout the day is absolutely phenomenal. The volume is absolutely massive. So what goes wrong in this fantastic little system to cause the osteoarthritis? Very large numbers of people are actually attending clinics all over the world with osteoarthritis, and these are just some of the figures from the UK. And you can see that there's an age-related incidence of osteoarthritis, and which we can split up individually between hip and knee. So that between the ages of 45 or so and early 60s, large numbers of people are consulting their doctors with symptomatic osteoarthritis, particularly of the knee, and to a less extent of the hip. Historically, we know the hip replacements were the first joint replacements to be produced, because from an engineering point of view, they were slightly easier to build. Whereas now, in most countries, knee osteoarthritis is a much more common problem. What about the risk factors for knee osteoarthritis in Western society? Well, female gender. And that's partly related to the fact that that us boys die well before our wives and female colleagues. Obesity is clearly a risk factor for developing knee osteoarthritis, and previous knee surgery or significant knee trauma is also an associated factor. Other minor things are to do with occupation, such as heavy lifting, kneeling, or squatting on a frequent basis. I'm told, and this is based around an epidemiological study which was published in 2011, that hip osteoarthritis is relatively uncommon within Asia. The strongest associations identified in this particular paper are to do with injury to the hip, climbing large numbers of stairs, 15 floors. I'm not sure how often that occurs, but maybe if people live in large condominium, that they may have to do this, carrying heavy weights. But a weak association for hip osteoarthritis is actually being overweight. Whereas for knee osteoarthritis, like Western knee osteoarthritis, older age, female gender, and obesity. The older age one now, we need to put a brackets around, because we're actually seeing osteoarthritis developing in younger and younger people. And as I get older, I regard younger and younger as being quite significant. If we just consider these two things, disability-adjusted life years and years lived with disability, these are WHO definitions of trying to measure the impact of disease in general. In Europe, and I suspect this is very much the same across most of the world, though I've not found the figures, osteoarthritis is the 8th leading cause of a burden of disease in terms of DALYs. So that means the population of Western Europe is getting on for 1 billion people. So you can understand the impact just in Europe, here in Asia, where you have several billion people. The economic impact of osteoarthritis is really quite phenomenal. In terms of years lost to disability, musculoskeletal disease is highlighted by the large arrow there. And although to the left, it's neuropsychiatric disease is by far the most common problem, musculoskeletal disease is a massive cause of years lost to disability. And I suspect that if the figures were looked at properly, musculoskeletal disability would actually should be much bigger than that in a global sense. And we know, obviously, that there is an age distribution. There's a female and male disparity. The female figures are shifted to the right. Again, females tend to live longer than males. When we're thinking about osteoarthritis, we need to think about the synovium. Let me put it to you that is actually damage to the synovium, which is causing the osteoarthritis. Synovium is a fascinating tissue. Normal synovium is literally 1 cell thick. It consists of fibroblasts and it consists of monocytes. Monocytes are inflammatory cells. We did an experiment. I'm afraid they don't show up totally well. The contrast is not really very good. The left-hand image there is of a fairly low-key synovitis, and these are taken from the shoulder. The right-hand image is actually of an inflammatory synovitis, and this is in response to probably something fairly simple within the shoulder. I can't remember exactly. If we look at those histologically, there is a very great deal of difference between the minimal synovitis and the inflammatory synovitis. This inflammatory tissue is full of inflammatory cells, particularly including monocytes. Synovium is also peculiar in that it's probably about the only tissue in the body that does not stop growing when the cells meet each other in their growth, in their tissues. And so synovium splits and becomes fronded and develops villi in an uncontrolled fashion. And this was described really quite some years ago. And so that when the synovium is damaged, we see this massive villous formation of synovium, which continues to evolve. We did some really fairly simple experiments, in vivo experiments, looking at synovial fibroblast cultures, and we fed them with some interleukin, with some hydrocortisone, and some hyaluronan. Hyaluronan is an essential part of the synovial fluid. Interestingly, hyaluronan actually varies in size. Some of the hyaluronans are pro-inflammatory, some of the hyaluronans are actually anti-inflammatory. In this experiment here, I'm not sure how well, no, again, sorry, I apologize, the contrast is not showing up, but essentially the take-home message from this is if you feed synovial fibroblasts with interleukin-1 beta, it causes proliferation of the cells, and so they grow, they multiply, but actually they don't migrate, they don't move, whereas in the others there are variations. So synovium responds to an inflammatory stimulus. So we need to ask ourselves, what is the role of synovium in the etiology and progression of osteoarthritis? And is it just simply reacting, or is it actually a primary tissue which results in the initiation of osteoarthritis? And certainly I think the evidence is now beginning to be accumulated to suggest that in many cases of osteoarthritis, it actually is part of the initiation of that process. Obesity. We all know the definition of obesity, though recently our chief medical officer said that obesity is not a disease. So according to this definition here, obesity is a medical condition in which excess body fat has accumulated to the extent it may have a negative effect on health, leading to reduced life expectancy and/or increased health problems. Not may, it will. Cross out may and put will. These are the Western BMI measures. Here in Asia, the BMI at which one becomes overweight is actually slightly lower, usually quoted as 24 rather than 25. We know that obesity is a global problem. Famously, the USA, Australia, the UK have lots of obese people. Actually, Australia is one of the worst countries, which I've always found slightly surprising. But there probably in the last few years, to some extent, there has been a plateauing of the number of people who are obese in many Western societies. Here in Southeast Asia, I do quite a lot of work in Malaysia. Malaysia has the biggest obesity problem of, well, certainly of this selection of Southeast Asian countries. So 44% of people in Malaysia are overweight or obese, at least 44%. Globally, in 2013, it was estimated that 2.1 billion people are obese. I find that number really quite mind-boggling, really. Think of that in volumes of body fat. How many swimming pools, how many football stadia full of body fat makes 2.1 million people obese, billion people obese? Here in India, these are figures that I just picked up from the internet, 270 million people below the poverty line, but the third most obese country in the world. That was India Today in June of 2014. Times of India, April 2016, India most underweight people ranks 5th in obesity. Put that in terms of numbers of people here in India who are obese. 3.7% of the global numbers of men are here in India who are obese, and 5.3% of the global total of women are obese here in India. And even more worrying, 20% of Indian children are overweight or obese. So this is a problem for the future, not just for now. It will continue to the future. Fat children become fat adults. Globally, 1 in 5 children overweight or obese in the OECD countries. The obesity rates in the West, probably stable, but increasingly obesity is a problem of poorer countries. And this is one of the contradictions that you have to understand, that many people are obese, but they're actually malnourished. There are a lot of micronutrients that are missing from the poor quality diet. And these cause major problems with metabolism in general. So we need to have the concept of the malnourished obese. And of course, we know that virtually all public health initiatives actually fail to reduce the problem of obesity. We probably should measure the percent body fat rather than just BMI. Hip to waist ratios are also quite valuable, and obesity is very easily defined just by simply measuring yourself around the waist and measuring yourself around the hip. And if it's greater than 90% in males and 83%, I think, in females, then I'm afraid you're obese. One of the systemic problems is that the obesity is often associated with abnormal lipid profiles. But you also have to remember there are some people who appear to have a normal BMI, but do have an abnormal lipid profile. So it's not just the obesity itself, it's also the dyslipidemia that many of these people have. And visceral fat is highly pro-inflammatory. So that fat that's sitting in your omentum, around your gut, is causing massive problems to you. But there is a slightly bizarre notion. There is this obesity paradox, so that as one gets a little bit older, 60s to 70s, it's actually quite worth being a little bit overweight, and particularly for females. But that means only a little bit overweight, not obese. So what does obesity mean in terms of systemic disease? Well, we know that it's associated with the development of type 2 diabetes. We know that it's associated with an increased risk of cancer of various sorts. We also know that it's associated with the development of non-alcoholic fatty liver disease. And it's also associated with the development of osteoarthritis. I'm sure many of you know what the definition of metabolic syndrome is. Disorder of energy utilization and storage, diagnosed by a co-occurrence of 3 out of 5 of the following medical conditions: abdominal central obesity, elevated blood pressure, elevated fasting plasma glucose, high serum triglycerides, and low HDL levels. And so you just got to have 3 out of the 5 of those, and the WHO definitions back in 1999 are fairly clear on that. So if your adipose cells become fat, then actually they start producing pro-inflammatory adipokines because they're losing their blood supply. They can't get the blood properly to those cells. But worse than that, there's also a decrease in anti-inflammatory adipokines, and so that then gives rise to systemic inflammation, the so-called metabolic syndrome, to insulin resistance, to dyslipidemia, fatty liver, and all the other things that we see in association with metabolic syndrome. So Western lifestyle gives rise to these changes that we see systemically, and that gives rise to this whole plethora of different diseases, including probably some association with Alzheimer's and such things. But we can look at that in terms of the cellular mechanisms. One of the primary effects of these abnormalities is actually on the endoplasmic reticulum, which gives rise to a condition called unfolded protein response, and that itself is inflammatory, and there's a positive feedback system that occurs, such that once you've got the inflammatory response from these unfolded proteins, that causes more inflammation. And there's a mismatch between those things that are pro-inflammatory and those things that are anti-inflammatory, such that the pro-inflammatory responses win. So So the endoplasmic reticulum produces these poorly completed proteins that gives rise to inflammation, gives rise to the production of reactive oxygen species, and we get this positive feedback effect. And that in itself causes all these problems here that we've already alluded to. And we can look at this in terms of the diseases and what they're causing at the cellular level: endoplasmic reticulum stress response and oxidative stress response. And that causes all this damage, or seems likely to cause all this damage within our bodies. We've recently completed a study in Malaysia on ethnic Malays in an urban and rural community. We only looked at 175 participants. These were people just literally off the street. 91% dyslipidemia, 43% type 2 diabetics, 56% cardiovascular disease. Something like a 25-fold increased cardiovascular risk overall within this study. What was interesting was that a high percentage of these people were completely undiagnosed. But even those who were diagnosed, many of them actually didn't take the therapy anyway. They believed in using the traditional healers and such things. But what was also interesting is that functionally they seemed to be able to continue, even though they really had very, very severe disease. Some such that we really had to get them, talk to them very severely in some sense, to get them to try and get treatment. What about obesity and osteoarthritis? Well, clearly there's some patients who develop osteoarthritis who have trauma to their joint. They're actually physically damaging the articular cartilage. And we see this if we look at the arthroscope, we look at surgery. There's actual physical damage to the articular cartilage, but there's also, in every single case, synovitis. But in so-called primary osteoarthritis of joints, there's no obvious trauma of that sort. And there's this concept of metabolic syndrome osteoarthritis now being developed. So there's an intra-articular inflammatory reaction in the synovium that is exacerbated by the systemic inflammation associated with metabolic syndrome, poor cartilage nutrition, poor cellular function, and so progressive changes which give rise to the osteoarthritis. So we need to think of osteoarthritis as not just being mechanical damage to the joint cartilage. It has an inflammatory component. Osteoarthritis is an inflammatory arthritis. It is not degenerative mechanical osteoarthritis. It is an inflammatory condition. Obesity, part of metabolic syndrome, pro-inflammatory. There are common cellular mechanisms that are in operation. So in that central box, you could put metabolic syndrome. We've slightly cheekily put osteoarthritis in there. But the point being, all these things, the dyslipidemia, the obesity, the hypertension, the type 2 diabetes, are all actually working in concert with the changes that are going on inside the knee joint and the other way around. There's a contribution from the joints to the systemic inflammatory load, and the other way around. The systemic is affecting the inflammatory load within the knee joint or other joints. We know that the number of joint replacements is increasing in the UK, but importantly, patients who are obese who are receiving their first joint replacement now coming down in age quite considerably, due to this association of the synovitis, the inflammation in the joint, and metabolic syndrome. Just very, very briefly tell you a bit about an experiment which we've been ongoing now for about the last 6 or 7 years, and actually involves about 3,000 patients and 5,000 odd samples, looking at inflammation function in patients undergoing knee and hip surgery. We've measured a molecule called S100A8A9 or MRP814, which is a monocyte recruitment molecule which floats around in the circulation. When the monocytes leave the circulation and become tissue macrophages. And I won't go into all the details of that, but it's a very simple molecule to be able to measure. It can be measured by an ELISA, and this is on the first 1,800 blood samples. We've now got over 5,000 blood samples we've done the measurements on. And we measured various scores as well as the S100, A8, A9. What was interesting here, certainly in our UK practice, 87% of arthroplasty patients were overweight or obese. The greater numbers were in knee replacement, so more patients with knee replacement were fat, but also, worryingly, 93% of the younger people under 65 needing knee replacement were fat, overweight, or frankly obese. The other interesting facts are the ones down the bottom there. The platelets, which are involved in inflammatory response, and the monocyte counts were gender specific, but also there were increases in both of those. Lots of these patients had comorbidities, and many of them were on multiple medication. As orthopedic surgeons, we can pat ourselves on the back. Joint replacement does work. Improvement in SF12, improvement in a joint-specific score. But the most important point here is that when these knees were replaced, the total systemic inflammation, as measured through the S100, A8, A9, diminished. Did not go down to what is recognized as the normal level, which is around about 2. But it actually significantly decreased, suggesting that the inflammation going on in the affected joint was having a systemic effect. So inflammation impacts negatively on joint function and general physical well-being. Our data, osteoarthritis, age, and obesity each contributes to increases systemic levels of inflammation. Systemic inflammation resolves significantly after joint replacement. We can't change age, but maybe joint replacement is actually quite a good thing. So osteoarthritis patients exhibit gender-specific inflammatory profile in terms of platelets and monocyte counts. If there's a reduction in inflammation following arthroplasty to surgery arthritis surgery in lower limb patients with osteoarthritis, indicating that there are inflammatory drivers within the joint tissues which are contributing to systemic levels of inflammation. So patients who are obese with osteoarthritis require joint replacement a mean of 59 years, whereas patients with age-related hypertension, 74 years, 15 years difference. So obesity is not just a problem of weight. Obesity, metabolic syndrome, osteoarthritis all contribute to this total systemic inflammatory load. Joint arthroplasty reduces the measurable inflammatory load, but it never goes down to normal. We know that osteoarthritis affects multiple joints, and the majority of our patients certainly had at least one comorbidity. So the inflammatory components of obesity and osteoarthritis interact. There are molecular mechanisms probably related to endoplasmic reticulum stress, which are important, and joint arthroplasty reduces inflammation. We've got a global problem here of both obesity and osteoarthritis. Maybe obesity in the West has stabilized. Certainly the number of joint replacements is still increasing. Importantly also, patients who are receiving arthroplasty who are obese are actually getting younger, and that is obviously a worrying trend. And we need to get proper health improvement strategies which target both the problems of obesity and osteoarthritis, but especially in younger people. Thank you very much.
Thank you very much, Dr. Simon, for such an engrossing session. Now the session is open for discussions. So any questions from the audience, please? Any questions?
Stunned silence. No, they don't want to. Don't wish to ask me anything. Oh, good. Oh, good.
My question is that you showed that Malaysia has got highest incidence of osteoarthritis.
Those are obesity figures. So, yes.
But they also practice a type of therapy called reflexology. Do you have any idea about it for the treatment of osteoarthritis to reduce the pain?
There are lots of different modalities that reduce pain, the pain of osteoarthritis, and Yeah, certainly I don't think any of the orthopedic surgeons here would say that joint replacement is the universal panacea. And if pain can be controlled, then sometimes non-operative means remain useful. Reflexology, pain management, physiotherapy, all these things can contribute to that. The point that I think that I'm trying to make is that we really need to think as orthopedic surgeons holistically about the patients. Yes, we can replace their joints, but if they remain fat, it's going to still continue to cause problems. And when we're assessing patients for such surgery, we need to understand all the things that are going to be going on in that patient as a consequence of their obesity and the metabolic syndrome, as well as what's happening in terms of the osteoarthritis.